Thank you so much, Angie. I appreciate that. Thank you for being here today, and thank you to you all. Today, we are going to be discussing methylation and clinical practice insight from the doctor's data methylation profile. So let's begin. Currently, there's a lot of talk about methylation, and some of the information out there is excellent, and some of the information out there can be a bit misleading. So today, we will go through the details of the methylation cycle and understand the role in human physiology. And hopefully by the end of this presentation, you will walk away with a great understanding of how to utilize methylation to best help your patients. We are going to explore the clinical significance of methylation imbalances, and we're going to review the components and interpretation of the doctor's data methylation profile. And lastly, we will use case studies to understand the applications and therapeutic strategies based on methylation status. What is methylation? Shortly, methylation is the biochemical process of adding a methyl group to a molecule, maybe DNA, RNA, proteins, hormones, histamines. According to Dr. Jill James, a pioneer in the field of methylation, methylation is an integrative profile reflecting the combined effects of genetics, epigenetics, diet, nutrient insufficiencies, and environmental toxicants. As we will see, methylation is at the crux of human physiology, merging and implicating multiple systems of human health. Methylation is involved in gene regulation, so DNA methylation can silence or activate genes without altering the DNA sequence. Therefore, methylation is crucial to epigenetics, and we know epigenetics is essential for governing physiology. Methylation is involved in detoxification. It's helped to process and eliminate toxins, hormones, and heavy metals, especially arsenic. Methylation is involved in neurotransmitter synthesis and metabolism. So as we will see, it is intricately involved in the production and the breakdown of dopamine, serotonin, melatonin, even the creation of melatonin. We will also see that methylation is involved in cellular repair and replication. It is essential for DNA and RNA repair and cellular division. It also plays a direct role in cellular membrane phospholipid metabolism. And methylation is crucial in homocysteine metabolism. It converts homocysteine into methionine, impacting cardiovascular and neurologic health. In short, methylation is like a molecular switchboard, capable of turning genes on or off, therefore modulating biochemical pathways and adapting to environmental inputs. Methylation is dynamic, responsive, and deeply tied to stress and lifestyle and nutrition. As we will see, methylation plays a direct role in host physiology. Today, we are going to discuss the folate and methionine metabolism cycles, as these are clinically relevant and intricately linked. Disruptions here may be due to nutrient deficiency, genetic polymorphism, such as that infamous methylene tetrahydrofolate reductase, MTHFR enzyme, or even oxidative stress, as all of these factors can play a role to impair detoxification, epigenetic regulation, and redox balance. So my apologies, but we will be reviewing biochemistry today. So here we have the sample of the folate metabolism in the 1-carbon cycle, also known as methylation. On the left, we have the folate cycle, which begins with the ingestion of dark green leafy vegetables. The term folate comes from the Latin word folium, meaning leaf. So think of foliage, which is quite fitting. Before folate can do its job and enter and link with the methylation cycle, it must be converted in the liver and the cells. So folate is converted through multiple steps. We have the ingestion of the dark green leafy vegetables, and then we have folate metabolism. And approximately halfway through that, we form folinic acid. Folinic acid, then a few steps down, is further converted into active methyl tetrahydrofolate. So that's 5-methyl THF, as we see there in green at the top of the folate cycle. Then the MTHFR enzyme is integral here because the folate cycle connects to the methylation cycle via multiple enzymes. We have the MTHFR enzyme, and then we also have the MTHFR enzyme, which brings in the important B12. And then we have the MTR enzyme, which remethylates homocysteine to methionine, so methionine synthase. This metabolic handoff is at the heart of one-carbon biochemistry. As we will see, we need methylated folate, so 5-methyl tetrahydrofolate, and we need B12 and zinc to remethylate homocysteine to regenerate methionine. On the right side there, we have the methionine cycle. To begin, methionine enters the methylation cycle that we will discuss as a sulfur-containing amino acid. It is then converted to SAMe, s-Adenosyl methionine. So SAMe is very important because this is the body's primary methyl donor. SAMe will donate its methyl group. And here is where we have myriad implications in physiology, because that donated methyl group can go on to support membrane phospholipids. It can go on to support neurotransmitter synthesis, metabolism, DNA repair, RNA repair, DNA methylation. After that, SAMe becomes SAW, which then becomes homocysteine. So at the bottom of the cycle, you can see homocysteine there. Homocysteine can then be recycled back up to methionine, so that is the primary route, and this keeps the methylation cycle running smoothly. As you recall, recycling homocysteine back up to methionine is intricately linked to the folate cycle, and especially methylated folates, as well as the important B12. The other option for homocysteine is that it can exit via CBS enzyme to contribute to endogenous detoxification, transsulfuration. This enzymatic pathway acts as an escape hatch. So when methylation demand is low or oxidative stress is high, the methylation, the homocysteine will go down to create glutathione, endogenous transsulfuration, and detoxification. So that is the cycle there. So we know that folate and methionine cycles form a dynamic exchange system where methyl groups are passed along the cycle, donating methyl groups, which go on to regulate gene expression, neurotransmitter balance, hormone metabolism, and detoxification. As we see here, that methionine metabolism pathway is at the top right of this biochem pathway chart. Just to the left of that, we see the folate pathway. So we see that reduced folates, that's the intake of dietary greens traveling down through the folate metabolism pathway. And the connection at the very bottom of that folate pathway is the MTHFR enzyme. And at the bottom right of the folate of the methionine metabolism pathway, we see homocysteine there. So homocysteine is at the bottom of that methionine pathway there. And homocysteine, as we mentioned, can either get remethylated back to methionine, so connecting to the folate metabolism pathway there, or it can exit via CBS, so going down the pathway, to generate glutathione, taurine, and sulfate for redox defense and bioconjugation. That's really what we're going to be talking about today. But we want to understand how these biochemical pathways are not in this singular system. They're intricately connected to multiple systems. So on the left of this pathway planner, we can zoom in. So we're exiting the one-carbon metabolism, and we're zooming in on aromatic amino acid hydroxylation, where we see tetrahydrobiopterin, indicated by BH4 on here, steals the spotlight here as a methylation adjacent cofactor in the synthesis of several key neurotransmitters. This system depends on folate cycle dynamics. As you see, it's connected there. Additionally, SAMe, the key methyl donor that is produced in that methionine cycle, remember, modulates enzymes that use tetrahydrobiopterin, such as tryptophan and tyrosine hydroxylase, making tetrahydrobiopterin availability and methylation capacity deeply interdependent in maintaining neurochemical balances. Further down on the left, we will see neurotransmitters and we will see COMT and MAO-A. So we see that these enzymes here involving neurotransmitter pathways, they use SAMe to methylate catecholamines. So that SAMe that is created in the methylation cycle is utilized over here as well. Here we have an implication for mood disorders as imbalances in COMT and MAO-A activity, whether a genetic polymorphism, a nutrient insufficiency, or lifestyle consideration, epigenetics, that activity can shift neurotransmitter tone towards anxiety, depression, or irritability. So importantly, methylation status impacts how efficiently these enzymes function, and nutrient status, diet, influences this whole system as these nutrient components are key cofactors in the biochemistry pathway for enzymatic reactions. And so that is why when we say that methylation is a complex system involving many different aspects of physiology and is associated with genetics, epigenetic or phenotypic expression, as well as nutrient and lifestyle factors. As we have seen in biochemistry, methylation imbalances have myriad impacts upon physiology. These are associated with cardiovascular risk, as impaired methylation can elevate homocysteine, increasing the risk of stroke, atherosclerosis, and heart attack. Implications include neuropsychiatric disorders, as disruptions in methylation affect neurotransmitter metabolism, contributing to anxiety, depression, ADHD, ADD. And then additionally, you have the implications of the COMT and the MAO-A gene variants. Detoxification is involved, as reduced methylation capacity can hinder clearance of heavy metals, estrogens, and xenobiotics, leading to toxin accumulation and hormonal dysregulation. Reproductive health is intricately related here, as methylation defects are linked to infertility, recurrent miscarriage, hormonal imbalances, particularly in individuals with MTHFR variants. Additionally, aberrant methylation can silence tumor suppressor genes or activate oncogenes. These epigenetic changes are early biomarkers in cancers like breast, colon, and lung. And lastly, autoimmune conditions are associated, as methylation imbalances may lead to loss of immune tolerance, contributing to diseases such as lupus, rheumatoid arthritis, and multiple sclerosis. So how would we test this system? There are two options: genetic testing for SNPs or functional testing for biomarkers like SAM and SAW. While genetic testing reveals your genetic potential, SNPs like MTHFR, MTR, and MTRR, functional testing shows how these genes are actually behaving in real time. So functional testing reveals the phenotypic expression. This data can guide real-time interventions like adjusting methyl donors, B vitamins, or detox support based on your patient's history and presentation and current needs. This allows for personalized interventions. And methylation patterns, as we know, are epigenetically influenced by diet, stress, toxins. So functional testing captures these shifts, allowing for monitoring and course correction over time. Genetic testing data indicates genetic potential, and genetic testing can certainly play a role, yet alone, this may not lead to proper supplementation without understanding the context of the phenotypic expression. For the functional assessment of the methylation cycle, this would be a plasma specimen, and this requires a venipuncture. The analytes tested will be methionine, SAM, SAW, homocysteine, cystathionine, and cysteine, as those are the biomarkers of the methylation cycle. We'll also look at the SAM-SAW ratio. A fasting collection is recommended, as this emphasizes metabolic problems and minimizes dietary influences. For 48 hours prior to collection, discontinue taking dietary supplements containing methionine, cysteine, and SAMe. Supplements are always at the discretion of the physician. So here we see this diagram illustrate the core methylation and homocysteine cycle, showing how the implications for B12, B6, and choline betaine interact to regulate methylation detoxification and amino acid metabolism. We are going to look at today the values of methionine, SAM, SAW, homocysteine, cystathionine, and cysteine to understand the methylation cycle. These are the biomarkers that we will evaluate. Methionine. Methionine is an essential amino acid that's found in animal proteins, moderate in nuts, seeds, and legumes. This is the starting amino acid in nearly all protein synthesis, as it's coded by the AUG start codon, signaling the translation of messenger RNA. This is the precursor to SAMe, the body's universal methyl donor. Too little indicates impaired detoxification, low glutathione status, and poor detoxification. But too much is associated with elevated homocysteine or oxidative stress. SAMe. In the methylation cycle, SAMe is the primary methyl donor. This is involved in methylation, neurotransmitter synthesis, and detoxification. It is synthesized in the body from methionine and ATP via the enzyme methionine adenylyl transferase. Again, this is the primary methyl donor. So SAMe goes on to give methyl groups to stimulate epigenetic regulation of DNA and histones, neurotransmitters, membrane phospholipids, and detoxification pathways. SAMe is associated with enhanced monoamine synthesis and depression, and caution with supplementation, as this can trigger mood disorders, especially in individuals with polymorphisms associated with COMT and MAO-A. SAW is the next step in the pathway. So SAW is formed when SAMe donates a methyl group. The level of SAW is very important because SAW can inhibit the methyltransferase enzyme, therefore slowing or blocking methylation reactions. So the level of SAW is an important biochemical marker. SAW is reversibly hydroxylase into homocysteine and adenosine by the enzyme SAW hydroxylase. This enzymatic reaction does favor SAW formation. With regards to SAW, the level of B12 is actually critical to the formation of homocysteine and the clearance of SAW. Elevated SAW is associated with cardiovascular disease, neurodegeneration, and epigenetic dysregulation. Homocysteine. Homocysteine is the next step in the process. And homocysteine is an essential sulfur-containing amino acid. This is a clinical biomarker for cardiovascular disease, neurologic disease, and it is hydrolyzed into homocysteine, and SAW is hydrolyzed into homocysteine and adenosine, but we are just going to measure homocysteine. Homocysteine is a biomarker for cardiovascular disease, neurological, and methylation-related dysfunction. Homocysteine can be remethylated back to methionine via the primary route, as we mentioned, utilizing the enzymes MTR, and MTHFR. Additionally, homocysteine can be remethylated back up to methionine via the secondary route, and that's the BHNT enzyme involving betaine. The body normally utilizes the primary route, but the secondary route is available in the kidney as well. And homocysteine third option could be transsulfuration down to cystathionine and cysteine via the CBS enzyme. So Dr. David Quigg likes to say that methionine is homocysteine methylated, which is true. This whole cycle is about adding a methyl group from methylated tetrahydrofolate, MTHFR enzyme, the folate metabolism pathway, and adding that to homocysteine and taking it back up to creating methionine. And the whole methylation cycle starts again. So all of these analytes are intricately linked. And we do not want elevated homocysteine because hyperhomocysteinemia is associated with endothelial dysfunction, atherosclerosis, neurodegeneration, mood disorders, and pregnancy complications. So evaluating optimal levels of homocysteine is a very important biomarker. If homocysteine exits via the CBS enzyme, it creates cystathionine. So cystathionine is formed via the reaction between homocysteine and serine via that CBS enzyme. This is dependent on vitamin B6, but this is a key intermediate in the transsulfuration pathway. When homocysteine becomes cystathionine, this is going to travel down to methylation transsulfuration balance, cysteine, and glutathione production. So cysteine is very important. Clinically low cysteine may impair detox capacity and immune function, while excess can contribute to oxidative stress or excitotoxicity. It also plays a key role with regards to transsulfuration pathway downstream of homocysteine and cystathionine. So we know that cysteine is the rate-limiting amino acid in glutathione synthesis. It is the least abundant in tissues and the most vulnerable to oxidative depletion. So therefore, its availability directly controls the rate of glutathione synthesis. We're going to take a look at this as well. So, a functional assessment of the methylation cycle evaluates how effectively the body is managing one carbon metabolism beyond just genetics by measuring key intermediates in the methionine and transsulfuration pathway. Functional assessment provides a real-time snapshot of methylation dynamics, nutrient sufficiency, and potential metabolic bottlenecks. This functional assessment bridges the gap between genomic potentials such as MTHFR and phenotypic expression. The methylation index is key here. This is defined as the SAM-SAW ratio. This is a functional marker of the body's methylation capacity, essentially how well your cells can donate methyl groups for critical biochemical reactions. This is created by the division of the concentration of SAM by SAW, inferring the methylation capacity. A low ratio is associated with global hypomethylation, affecting gene expression, detox capacity, neurotransmitter metabolism, elevated homocysteine and cardiovascular risk, impairing epigenetic regulation and redox balance. A high ratio may reflect oversupplementation with methyl donors, maybe SAM or betaine, or genetic variants such as a BHMT or AHCY polymorphism. Here we have an example of a low methylation index, typically defined as a low ratio of SAM to SAW. Again, this is a critical marker of methylation capacity and epigenetic health. This low methylation index may be due to MTHFR polymorphisms, B vitamin insufficiency, betaine or choline insufficiency, oxidative stress, liver dysfunction, and not seen here, but excessive methionine load. Low availability of methyl groups as a result of a low methylation index leads to adverse physiologic complications implicating DNA, RNA, protein, membrane phospholipids, neurotransmitters production, neurotransmitter metabolism, neurotransmitter receptors. Therefore, a low methylation index is associated with aberrant neurotransmitter metabolism, gene expression implicating cancer, cardiovascular, vascular health, birth defects, congenital heart disease, response to environmental toxins. And we saw in the biochemistry how we can see if we have issues with the methylation index, how that can explicitly impact physiology. Remember, in biochemistry, a low methylation index impacts multiple systems of biology, suggesting impaired methylation potential or a backlog in the methylation cycle, possibly elevated homocysteine or SAW accumulation, which inhibits methyltransferase enzymes. A low methylation index is associated with cognitive decline, mood disorders, cardiovascular disease, impaired detoxification, DNA hypomethylation, and this can lead to genomic instability. Now let's take a look at some cases. Our first case is a 50-year-old female. This individual presents with the chief complaint of fatigue, also mild hypertension and occasional tingling in her hands and feet. The medical history consists of a family history of cardiovascular disease and early onset Alzheimer's. This individual has a history of anxiety lifelong and difficulty concentrating getting worse over the past 18 months. She has been vegetarian since approximately 40 years of age, so over a decade. Periodic use of methylated B complex supplements, as she has seen on Instagram, yet inconsistent use. Individual reports no alcohol but moderate caffeine intake and reports increased stress due to workload and caring for a parent. Here we see the results. So let's take a look at understanding this result and the biochemistry that we've discussed. So the information here is graphed. And the way that it's graphed is the first four analytes, methionine, cysteine, SAM, and SAW, those levels are graphed in a bilateral direction. So right there in the white, you have the mean, which is the 50th percentile. And then you have the green going to either direction. So that's one standard deviation above or below the mean. And that is still within normal limits. So that first analyte there, methionine, is right at 1.8 because that's also the second standard deviation in the yellow to the left, and to the right is also within normal limits. So for this individual, we can see here that that first value of methionine is technically on the lower end of the reference interval at 1.8. And then we're taking methionine and we're stepping down to SAM. And SAM is also within the reference interval directly to the left of the mean. So the value is at the distal portion of that bar that's from the mean. So for SAW, it is slightly above the mean. So SAW is at 17.6, slightly above the mean. So that is how this is organized. So if we want to understand the biochemistry for this individual, her methionine is low within range. Then stepping down to SAM is very adequately within range. Stepping down to SAW looks beautiful. That looks great. And then SAW, remember, SAW goes down to homocysteine. And homocysteine is high at the value of 12.7. So the reference interval is less than 11. So she has a high value of homocysteine. Remember, homocysteine can remethylate up to methionine. So that's involving the B vitamin folate metabolism pathway. So homocysteine back up to methionine, that's one option for this. Or homocysteine going down to cysteine and cystathionine. And cystathionine and cysteine actually are within range, cystathionine primarily first, and those are all within range. So for this individual, if we look at those values, the main consideration here is elevated homocysteine. Her SAM to SAW ratio is technically within range because SAM and SAW are actually pretty close together. So that's showing adequate methyl donor function. So for this individual, she has this elevated homocysteine, which is a significant finding. So clinically interpretation here. So her methylation index is functionally intact, but she has an elevated homocysteine alongside borderline low cystathionine and borderline low methionine. So this may be due to insufficiencies of B vitamins and also her vegetarian diet. So her homocysteine is higher at 12.7. Recall this individual has been vegetarian for about 12 years. So this may be lower intake. There could be lower bioavailability of this. Sometimes we see this with patients on PPIs. She also presents with fatigue and tingling in the extremities. And so for this, we're certainly thinking about her B vitamin status. So adding B6 there would help increase her cystathionine load. And then for her family history of cardiovascular disease, you want to continually monitor her homocysteine value. We don't want this to be this high now, and we don't want it to be this high at a later point in her life. Consider a comprehensive cardiovascular panel because we do want more information here, and consider testing for MTHFR, MTR, and MTRR. Now, this is a point in which those enzymes could be responsible for that elevated, that higher homocysteine level. Additionally, consider other polymorphisms associated with vascular health. Remember in biochemistry that we talked about. So here we have the Left side here is going to be that end product of the folate metabolism pathway. So on the end there, we have MTHFR, that enzyme. The end product is that methylated folate, that 5-methyl tetrahydrofolate. And then we have to the right of that, we have the methionine metabolism or the methylation pathway. So remember, we started with methionine. That's within range for this individual. Then we're stepping down to SAM. For her, she's doing well. Stepping down to SAW, that's fine. Then reversibly via the AHCY enzyme to homocysteine. Homocysteine is too high for this individual. So we have 3 options. Remember, our first option, the primary route, we're going to add a methyl group, that methyl group from 5-methyl tetrahydrofolate, and we're going to remethylate this or recycle this homocysteine back up to methionine. What do we need there? We need primarily B12 because that MTHFR enzyme is that smaller cogwheel. So you want to prime the system with B12. That's indicated in the light blue there. Then you want to add on that methylated tetrahydrofolate, which is in the green there. You can give that end product methyl tetrahydrofolate, or if you wanted to give the body something a few steps up in folate metabolism, because remember we talked about that, you can use folinic acid. Folinic acid is a few enzymatic steps before methylated folates, so you can add that supplement for that patient if you want to give the body a chance to do its thing. Again, we don't know the MTHFR polymorphism status for this individual. The second option is we can use that secondary route. So this homocysteine is high. We want to move it out of there because it's so harmful to physiology. So you can use betaine to stimulate that secondary route, and that's in dark green there. So taking it directly up to methionine, bypassing that first route that we discussed. And then last but not least, you can take homocysteine down via the CBS pathway to create cystathionine. Remember, it was borderline, so you can certainly do that for this individual, and that is in the blue there. So for this patient, her homocysteine level is high. That is not compatible with optimal health, so we'd want to move it out of this pathway using the biochemistry that we discussed here. So supplement doses are presented here for educational purposes only and at the discretion of the physician. Again, to reiterate, we're going to start with that methylated cobalamin, or you can use adenosine cobalamin or hydroxy. You're going to get that cobalamin in there, add on the methylated folate or folinic acid, so you're priming with that B12, adding the methyl group, and you're moving the homocysteine the primary route. Your other option is taking B6 and moving it down the CBS pathway to glutathione synthesis and endogenous transsulfuration detoxification. And then third, you could use TMG to take it up to methionine. She was not eating a lot of meat, right, because she's vegetarian. So you can bring these things up to methionine. That would likely make sense for this individual. So recheck in 8 to 12 weeks. Adjust the doses based on patient's response and tolerance. As many of you know, supplementing with B vitamins can be very individualized. So patients tend to have their own responses. Taking a look at our second case here. This is our individual that is a 59-year-old male. This individual presents with brain fog, low energy, and reports recent increases in blood pressure, averaging 132/88. Significant family history includes that his father had a myocardial infarction at 57 years of age, maternal history of type 2 diabetes. This individual is professionally active with a high-stress managerial role, struggles with sleep, and often skips meals during the day. So I'm sure you have these patients that are stressed, they're not eating, they have significant history and physiology, and they're presenting with low energy and brain fog. So let's take a look. So for him, we can see a certainly different profile. Again, we want to look at these in the pathway of the methionine metabolism. So methionine is the first one there. It's perfect right around that 50th percentile. That looks great. Then methionine steps down to SAM. So that's via the MAT enzyme. The MAT enzyme is highly flexible. So if you have a large intake of a methionine, it'll bring it down to SAM. and it's magnesium dependent. Now that we see there that SAM is very low. So remember, when SAM is very low, it is not available as a methyl donor. So we need that SAM because we need it to go on to stimulate DNA repair, RNA repair, neurotransmitters, hormones. We need SAM. And then conversely, that SAW is really high. So we're having a bottleneck there. SAW going down to homocysteine is technically okay. That homocysteine actually looks great at 7. But remember that this is a reversible enzyme. So that SAW could be going down to homocysteine and then going back up to SAW. So SAW is too high, SAM is too low. That is very poor methylation capacity. Next, we see homocysteine going down to cystathionine looks fine, and cysteine looks fine as well. The methylation index is important to note here that methylation index is outside the reference interval. This is a low methylation index. And I just want to reiterate here that the methylation index should be less than 4. The graph there is inverse. So when you have a lower methylation index, that graph is going to go to the right. So the low methylation index, his result is 2.5. We want it to be greater than 4. So low methylation index indicates low capacity for methyl donors. Okay, so the findings for this individual, that SAM is low. It's very low. It's 75. It's in the lower 2.5 percentile, so very low. That could be associated with the patient's presentation of brain fog and low energy due to the low methyl donor availability. That SAW is too high. Again, that low methylation index indicates reduced methylation capacity. For this individual, homocysteine is within normal limits. You definitely want to prioritize stress management for him. Consider heart rate variability training, breathing exercises, because the stress can play a role here. And consider genetic variants for that MAT enzyme, that AHC enzyme. We want to reassess these labs in 8 to 12 weeks after the protocol initiation. So what we will do for this individual. The primary consideration is this individual has a low methylation index. We want to increase the bioavailability of SAM. It takes 3 SAMs to create 1 phosphatidylcholine, and 70% of SAM goes on to create phosphatidylcholine, which goes on to create plasma membranes. So you can give the body phosphatidylcholine to increase the bioavailability of SAM. Supplements values here are always at the discretion of the physician. So potentially for phosphatidylcholine, 500 to 1200 milligrams, although some studies have shown that sunflower-derived phosphatidylcholines are safe up to 6 grams per day, and they can be used for up to 2 years. So there is some variability with that dosage there. Now, another option is when we want to increase SAM, what is before SAM? Methionine. So we can increase methionine. We could take a look at this patient's diet diary, add dietary red meats, tuna and turkey, and consistent meal intake. Remember, this individual is skipping meals, or you could consider supplemental methionine. Key here, though, when we do that, we want to consider that methionine adenosyl transferase enzyme, that MAT enzyme, which takes methionine down to SAM, is magnesium dependent. And as we know, magnesium is a very common deficiency. So we want to use magnesium. We can use L-threonate or taurate. So threonate is great because it crosses the blood-brain barrier. That would help this individual's overall health status. But then also taurate has affinity for the nervous system and cardiovascular tone, which is in this patient's history as well. Additionally, we want to get that SAW decreased. So we want to create a vacuum to decrease SAW to improve his methylation index. One of the main things we're going to do, remember, is cobalamin, because B12 primes that pump, and B12 decreases with age and absorption, right? So we know that B12 is lower as we age due to intrinsic factors. So you certainly want to consider the addition of B12 for this individual. So supplemental B12 is available. Methylcobalamin is already in its free form, and it doesn't require that gastric release, making it more readily available, absorbed in people with low stomach acid. If he's stressed, he may have low stomach acid. So you can certainly add B12 to this individual, and this is going to help potentially with the chief complaints of brain fog and energy. Again, there may be a dietary tweak as well. Make sure the patient's not on antacids or proton pump inhibitors. Age, proton pump inhibitors, stress, they can all impair the absorption here, okay? Now, again, supplementation dose is individualized and up to the physician. You do have your choices. So methylcobalamin is going to be the one that is normally considered supporting neurologic and methylation pathways, but the body can actually utilize other forms such as adenosol and hydroxy, and then it will convert them to methyl. Adenosol has affinity for the mitochondria, and so therefore in this individual, that might be a good choice because it has affinity for mitochondrial health, and low energy is a chief complaint. So you could also use a supplement that has multiple forms in it. So we see these more often, a supplement that would have a methyl and adenosol in that. Hydroxy is fine as well. Hydroxy is produced by the gut bacteria. The gut bacteria that produces cobalamin is found in predatory organisms. That's why meat is a source of B12 for us. Cyanocobalamin is a synthetic, inactive form, and that one is not recommended. Okay, so for this individual, again, we want to address the environmental stressors, oxidative stress, and inflammation that can elevate SAW and deplete methyl donors. Remember, this patient's under some stress. Of course, we want to add exercise and movement to support stress, energy, and sleep. And then as a question that often arises is SAM-E supplementation. Well, since that SAM is low, should we just give SAM-E? And it is a clinical decision. The considerations are that in functional medicine and systems-based medicine, we're always trying to give the body the smallest intervention so it can do its job. So we don't necessarily want to go in there and give a large dose of SAM and bypass all the biochemistry that we discussed, right? We're understanding the biochemistry and we're understanding where to make small interventions to help this individual. So instead of simply giving SAM-E, you're going to maybe give the substrate methionine via diet, or you're going to help that enzymatic MAT reaction via magnesium. That's your consideration. There are some considerations with SAM-E supplementation. We want to titrate this slowly, and some individuals feel worse, such as anxious and irritable, and have difficulty sleeping with that supplementation, and that may be associated with the polymorphisms, COMT or MAOA. So again, the supplement and prescriptions, the medication dosages here are at the discretion of the physician because they are very individualized. So adjust the dose and response of your patient, and you can check this in 8 to 12 weeks. And our third case here, our third case is a 64-year-old male that presents with anxiety and depression on and off for the past few decades. And you have these patients that have been dealing with these considerations for decades. And this individual was divorced recently, so everything has gotten worse in that regards. Known history of coronary artery disease, history of angina, and one prior angioplasty 2 years ago, currently on statins and a beta blocker, reports fatigue, mild cognitive decline, and erectile dysfunction. Significant medical history includes sedentary occupation. This individual tries to eat healthy, yet ends up with the standard American diet. It's a very convenient diet. No tobacco use, occasional alcohol, and a strong paternal history of premature myocardial infarction. Father deceased at 56, and the brother is diagnosed with hypertension. So here we see this individual's results. The first thing that we note there is that methionine is within range, so that's healthy, that's good. And then stepping down to SAM, that's also within range, but then we go to SAW, and SAW is very high. So we have excessive SAW here. And then we also have, stepping down to homocysteine, we have very high homocysteine at 11, not very high, but moderately high at 11.4. We know that that's associated with cardiovascular, and that's a consideration for this patient. And then what we see there is the SAM to SAW ratio is off because the balance of SAM, SAM is within normal limits, but functionally the value of SAM to SAW is so far off that methylation capacity, that balance, it's triggering that this is outside the reference interval. Cysteine and cystathionine are within range. So for this individual, SAW is markedly elevated. That's going to have downstream effects because this is an inhibitor of methyltransferases, impairing epigenetic regulation and neurotransmitter synthesis and detox and other enzymatic functions within physiology. And then that homocysteine is too high, associated with cardiovascular risk, and then that ratio is off there. So SAM is within normal limits. So we're not going to take any actions on SAM, but we're going to think about the patient's, how this is impacting physiology. And a question for this patient that we're interested in is maybe genetic testing, right? So when we look at this patient's genetic test, this patient has some findings that are associated with that chief complaint, the predisposition to anxiety. So the patient has struggled with anxiety for decades, and we want to understand a little bit about that, okay? Additional findings that we have here is we have the MTHFR homozygous for C677T. So this can potentially decrease that MTHFR gene expression, enzymatic activity by 60 to 70%. So that could be playing a role with regards to homocysteine, because remember, it's intricately connected to the remethylation of homocysteine back up to methionine. Additionally, in that neighborhood, we have MTR and we have MTRR, and the patient does have some SNPs in those areas. So we like to look at these SNPs together and see where they work together in biochemistry, because that will show us the extent to which the enzymatic activity may influence physiology. And of course, the activity of these enzymes is also dependent, as we discussed, on folate and B12 and things like that. So for this individual, we know he has a positive homozygous MTHFR C677T. He also has some SNPs for MTR and MTRR. And then he also has a SNP for BHMT, and he also has a SNP for CBS. So remember, all of those SNPs are involved in moving homocysteine. So all of those enzymes are responsible for moving homocysteine, and he has a higher level of homocysteine and then backing up potentially via AHCY to higher levels of SAW. So this is good data here to understand this individual's presentation with regards to that profile. As far as the anxiety goes, we do see a genetic SNP for the COMT, so homozygous COMT for V158M, and then we do see some other homozygous variants that are positive, as well as MAO-A. And then he does have the NOS enzyme, which is associated with vascular health, okay? So for this individual, he does have that MTHFR C677T. So this one is prone to decreased function of that enzyme, and that is implicated with elevated homocysteine hyperhomocysteinemia. He also has the NOS3 gene, and that is associated with endothelial nitric oxide synthase. And this is associated with vasodilation and vascular health, associated with hypertension, which the patient is presenting with, and coronary artery disease and myocardial infarction, which are also in the family history. Certainly a relevant finding here. And then for the patient has the COMT homozygous SNP here. So this has 2 copies of the slow variants. So his enzyme is slow at clearing dopamine, epinephrine, and this can lead to feelings of anxiety and stress. And maybe that is associated with the patient's chief complaint of anxiety for his lifetime. So this is associated with that. And then for these patients, sometimes we will be a little bit more calculated and a little bit more sensitive with the methyl donors, such as the ones that we've discussed. So this is good information for the consideration with the, using nutraceuticals to affect that physiology. And for this individual, we certainly want to consider stress management is going to be very important. Avoid excess catecholamines. Green tea, quercetin would not be indicated. Putting this all together for this patient. So the patient has genetic polymorphisms and has functional elevated SAW and homocysteine levels. We know this individual's methylation pathway is under strain due to the genetic influences and the biochemical accumulations of the intermediates SAW and homocysteine. The combination of MTHFR C677T, MTRR, MTR, BHMT, CBS significantly reduces the body's ability to remethylate homocysteine, resulting in elevated homocysteine and SAW and functional methylation defects. So these impairments likely contribute to the patient's potential for neurotransmitter imbalances, anxiety, depression, and are associated, especially that ENOS, with endothelial dysfunction and heightened cardiovascular risk. We can implement our protocol and recheck the methylation profile in 8 to 12 weeks. For that DNA test, the great thing about that is once you've done that test, you do not need to do that again for your patients because those genetics never change. Remember, that's the genetic component. But for the methylation profile, we can incorporate a protocol and we can recheck to see how those analytes have improved. So for this patient, we definitely want to monitor homocysteine. We can certainly add some cobalamin, maybe add an adenylyl cobalamin to move that pathway, to move that homocysteine. We need to get that homocysteine out of the way, and B12 is implicated to decrease homocysteine and decrease SAW. You can add on some folates, maybe some folinic acid, because we don't want to give too many methyl groups because of the genetic testing that we have. So of course, we're going to implicate support for endothelial health. We saw that there's a genetic disposition and a family history, so those go hand in hand. We're going to use omega-3 fatty acids, decrease inflammation, address the values of the patient's cardiometabolic profiles. We're going to implement nutritional and lifestyle interventions to decrease stress and address neurotransmitter imbalances. The patient had trouble sleeping, so that's associated as well. Consider, of course, a comprehensive cardiovascular panel and neurotransmitter testing and salivary cortisol testing to provide direct protocols. And I would consider glutathione testing for this patient too. All right. So at the end here, how are we going to integrate methylation testing into practice? One of the first things you can do is, if your patient has elevated homocysteine, run the plasma methylation profile because you want to see how the other analytes are functioning and how that patient's methylation cycle is occurring, because we know this is so implicated in physiology. For any patient that's dealing with chronic fatigue, mood disorders, cognitive decline, neurodevelopmental delays, a cardiovascular risk, detoxification considerations, recurrent miscarriage, fertility issues, even aging or longevity optimization, methylation can certainly play an important pivotal role in clinical practice. In conclusion, integrating methylation testing into practice, we do know about the SNPs because these are very well known. We know that SNPs certainly can impair homocysteine clearance. We also know that nutrient deficiencies, such as the B vitamins, can influence enzymatic reactions and transsulfuration pathways. So all of these considerations do commingle with regards to methylation. In conclusion, methylation is a fundamental biochemical process that involves transferring a methyl group to DNA, proteins, and other molecules. We know that this is involved in gene regulation, neurotransmitter status, detoxification, cardiovascular health, immune health, cellular repair, and even aging. A functional assessment of the methylation cycle is clinically relevant, and combining the epigenetic markers with the DNA SNPs is excellent decision-making and warranted in many cases. All right, thank you.